So we shall now go on to our next presentation by Dr. Sunil Shah, again leading private practitioner from Ahmedabad and from SUNIL SHAH Eye Hospital. And he is going to be showing us
from Varanasi.
Varanasi, I'm so sorry. So sorry, I'm very, very sorry. Oh my God, we spoke at length about your son's wedding. I'm so sorry. A leading private practitioner from Banaras, and he is going to show us two interesting videos. On to you, Doctor.
Thank you, Dr. Chitra, for inviting me to join this interesting webinar.
I'm starting the video.
Yes.
Yes. Patient is a young girl of 18 years, sustained injury with pataka, and she had a traumatic cataract with non-dilating pupil and Sanikyo present, all 360 degree. So we were very much afraid that this may have a subluxation. So we prepared ourselves with all the things like CTR and dilatation drops. Fortunately, the case started under local anesthesia. As you can see, the first step which I did was a subtenon injection of 1.5 ml Jalocaine. After injecting Jalocaine, there is total akinesia. You can see there is a very good block. And then we proceeded the case with capsulotomy, rhexis, with forceps, and hydrodissection by using bimanual irrigation aspiration. Because the capsule was lax and we had not planned for a CTR initially, but after seeing the capsular tag and the Sanikia, we could remove the tag and good opening was made. The polishing was done, and as the lens was little calcified, we did good irrigation aspiration using only 2 ports. You can see I am using the main port for the irrigation and there is no leakage from the wound. So we did an examination of the retina before injecting the IOL, and when we thought that everything is fine, we used viscoelastic and small amount of Elon GV to implant the lens into the bag. We have used a hydrophobic single piece lens, and sanitation was achieved by dialing into the bag, and all the viscoelastic and Elon was removed by two-way IA in the 2 ports only. It is very important to push the lens into the bag and maintain a position by using air. The air is used for 2 folds. Number 1, to tamponade the lens and also the wound. The most important part of this video was that pupil was not dilating initially, and it was a calcified lens. And if you have a pataka injury, then you are not sure whether the lens is subluxated or not. It was a very calcified type of problem with synechiae present. So I was not sure how to manage this lens in this case. So we did a block on the table just using 1.5 millimeter ml of Jalocaine subtenons. This is a very interesting series of the technique which I use on table giving block. So it prevents all the complications of a peribulbar and it prevents time also. The block comes immediately. So one tip is that, and the second tip is that during the surgery, synechiolasis was done, and then the pupil dilated using the lignocaine solution with adrenaline. The third interesting point in this video was that there was indirectly I saw the retina on the table. Then I used the lens because if the vitreous image is there, then we have to manage And luckily, B scan also showed that nothing was wrong. So the patient had good vision acuity at the end of the surgery. Can I have the second video, please?
Just a second.
80-year-old man with diabetes, having a grade 7 cataract and a leathery cataract. So we have used two very important steps. Number one, the half of the nucleus was removed using a 2.80 degree tip of the phaco, and then because there was a lot of problem in removing these pieces, we are using a technique known as spring technique, where a lens is put into the bag, a single piece lens, and then we use viscoelastic and Hilon GB to remove the last pieces. You can see this phaco tip is very straight, 0 degree tip. Using a high vacuum phaco, we are able to remove all the pieces of hard cataract safely without damaging the posterior capsule. There is no change in the collapse of the anterior chamber, as we are using a continuous irrigation mode. Continuous irrigation mode along with 2.80 degree tip is able to remove all the pieces. So this is the trick. When there is a very hard cataract, we have to be slow and we have to be very careful not to damage the last piece and the capsule. So all the nucleus is removed, cortex is removed, and then very importantly, air should be injected to prevent any desmus detachment.
So we've seen both your videos. Welcome, Dr. Mahipal. Have you seen this presentation? Should I take questions from you too? Or you've just joined in?
I think sir has just joined.
Okay.
I haven't seen it. Sorry, apologies. Next order.
Yeah, then going on I want the other expert panel to answer these things. In the first case, I think when he was done so many other evaluations, they should be prepared for a posterior capsular dehiscence too in a traumatic cataract. So an ASOCT could have been done and a hydro should not have been done in a total cataract, to my thought. These are just discussions. Both were very nice surgeries done by you, Dr. Sunil. Just to get more learning from it, I'm bringing up all these aspects. So could we have avoided a hydro because we do not know how the posterior capsule is because an ASOCT was not done? That is one thing in that particular case. And in the second case, would you do an AIOS scaffold when major part of the hard nucleus is out and a small piece is there, which if that bit of the surgery has been done so gracefully, you could have finished the surgery. Why put an AIOS scaffold in this particular case? Because with an AIOS scaffold, there is a compromise that you're actually doing an anterior chamber phacoemulsification and the endothelium could get compromised. But if you have a PCR, you are already in a state of compromise. You don't want the nuclear fragment to go into place, so you do it. So what's your logic about that scaffold?
Regarding the first question, madam, when I did a rhexis, I could complete the rhexis, but there was a strong synechia attachment, so which I could remove using a forceps. So I did a small hydrodissection and then saw that the chamber was not getting deep. So I thought because it was just a 18-year-old girl, so I used a bimanual system. I was prepared to use a CTR also, but I could manage because there was no pussy right.
And about your second case?
And most importantly, in this lady, in this girl, we did a block because once I started the case, I was not sure about the PC. So I injected 1.5 ml of lignocaine 2% and into the subtenon space during the surgery with my speculum on. I did injection. So it's a very good step because it doesn't create your
No,
There's
we
a
are not
leakage.
questioning your subtenon. We are asking why you placed an IOL scaffold in this case.
IOL scaffold, I think, is classically described when you have a PC rent and you don't want the pieces to fall down.
Yes.
So, because like you said, half of the nucleus was out, the other half would have also been out. So in an intact PC, probably you don't need a IOL scaffold.
Yes. And which would be a situation, Dr. Namrata, when we would not be able to place an IOL scaffold at all?
When
Yeah.
it's a very large PCR, then probably you will not be able to put a IOL scaffold. Maybe you can still try in sulcus, but I think that's going to be too tricky. And like you said, whatever said and done, IOL scaffold you can use, but I do feel it would to some extent do compromise the endothelium because you're coming a little more anterior in your plane of doing phacoemulsification.
No, but IOL scaffold, I think, can be placed if the rhexis is intact. Only if there's a rhexis
Only, yeah.
extension can you not
Do it.
place.
And if vitreous is already there in the anterior chamber, admixed with nucleus, again placing a IOL scaffold may not be a good idea because that's going to cause a lot of. So if you have a PC rent, but vitreous is still not in the chamber, but you have cortex and nucleus material in the anterior chamber, then you can place this as a tamponade to separate the vitreous phase from this thing. But vitreous is already in the chamber, maybe it's not a good idea. Another small observation is that, Dr. Shah, nice videos. You mentioned that you used a Helon during the second case. I think that's a cohesive viscoelastic. The moment you go in with your phaco probe, it's going to move out. So in these cases, if at all you want to protect the endothelium, maybe a dispersive viscoelastic would be a good idea. And that would be my choice. Something with chondroitin surface.
Yeah.
Any other, Anagha, would you want to add anything?
Yes, ma'am. Excellent videos, Dr. Shah. One more question I had for you. In your first case, you showed that you had only one side port and you were using irrigation from the main incision. Any specific reason why? Because probably there could be a lot of fluid leakage from the main incision and that could cause AC shallowing also.
I use normally a 2.2 incision, and it is my technique that I make this angle into the bend of the irrigating system. There's no leakage. Yeah.
Dr. Virendra Agarwal, we are hearing all your conversations.
Anand, please mute.
Please mute.
The angle of the irrigating thing is such that it blocks the port and there's no leakage.
Yeah.
If you see the video again, it is angled into the wound such way that it closes the wound securely and there's no leakage.
Yeah. Thank you very much, Dr. Sunil. I mean, you managed both the surgeries very well. It's just that there is always, we want to bring out all the parts of it. So thank you very much.